Hi, everybody. I'm Laura Gottlieb, one of the co-directors of the Social Interventions Research and Evaluation Network. I'm so happy to be with you today for this presentation, which we've titled Quality Over Quantity, Developing New Measures to Assess Patients' Experiences of Social Care. If you thought you were going to hear something different, well, maybe stay and just enjoy it anyway, or bye. Thanks for joining. I want to just first start by expressing our eternal gratitude to our collaborators at Kaiser Permanente, who um, really have had just tremendous vision and support over the course not only of this particular project, but also for so much of the work that they're doing on social care inside and outside of their organization. And that includes Kelly O'Neill and Alex Erkenbeck and Anand Shah. Just really grateful to them for supporting a lot of the work that SIREN does too, but also much beyond SIREN. So just a couple words about SIREN for those of you who aren't already familiar with us. So SIREN's a research and dissemination center at the University of California, San Francisco. Our mission is to conduct, strengthen, and synthesize research on social and medical care integration, and then to put it into the hands of people who can use it. So our audience includes not just researchers, but lots of people who are then changing practice, changing policy because of the evidence that's being generated in the field. One of our most beloved and well-used resources is our evidence and resource library, where you can find research and implementation tools about healthcare-based social care. It's free, it's available for everybody, it's really easy to use. Please don't hesitate to check it out and use it as you wish. Um, in addition, if you are interested in staying up to date about research in the field as it emerges, do sign up for our monthly newsletters. You'll see a synopsis of the relevant research that's been published over the last month on social care integration, and you can learn about recent or relevant or upcoming news and events. And to that end, I am going to announce to you that we are a planning partner for the research and evaluation track at this year's Putting Care at the Center 2026. Please consider submitting workshop proposals on social intervention evaluation topics that are relevant for complex care populations. Those workshop proposals are due on March 4th, so coming round the bend. All right, without further ado, I'm delighted to introduce today's panel, which includes two of my favorite people on the planet. First, Andy Quiñones-Rivera, who I met on their first day of medical school. Andy, I don't know if you can remember that far back. I actually don't remember what year that was, so that's how long ago it must have been. When was it? Yeah, they're trying to tell me, but I can't read lips. So prior to medical school, Andy told me that very day that they'd been a community health worker in the Bay Area. And what is remarkable to me is that they've been able to weave lessons learned from their experiences as a community health worker and so many other experiences to improve a lot of the work that they've been able to touch at SIREN. They've worked with us for many, many years. But after their postdoc fellowship with SIREN, they actually landed a position as medical director of acute care health outcomes with Alameda Health Systems, where they'll go on to influence so many more lives. Andy, we're really grateful you could take time to chat with us today about this work that you did before you left SIREN. And then, of course, the one and only Danielle Hessler-Jones, one of SIREN's co-directors and the brain powering so much of our research. In addition to all her social care work, Danielle has deep experience developing patient-reported outcomes measures in other fields, including related to reproductive justice. And she brought all that expertise on patient-reported outcomes to the project we're going to share today. So welcome, Andy and Danielle. A few logistics. The webinar is being recorded. A link to the presentation will be sent to everybody. We welcome your questions and comments, but please use the Q&A function, not the chat function. And we're trying to leave some time at the end of the presentation to get to as many of your questions as possible. Okay, so that said, I want to just tee up the presentation by offering a little context for this project. It will come as no surprise to any of you that over the last decade, we've seen a lot of policymaking related to healthcare-based social care, including screening and referral efforts. We've seen policymakers use every kind of lever, including guidelines, practices, standards, rules, regulations. Name your healthcare policy lever, and you'll certainly find something related to social care. But like many of the folks on this webinar, I think I realized that social care had hit the big time around 2023 when NCQA, CMS in several different value-based purchasing programs, and the Joint Commission all began developing quality measures or other standards related to social care. And at first I thought, this is amazing. Healthcare is being held accountable for social care. And then I thought, wait a second, healthcare is being held accountable for social care? Do we really know enough to say what the healthcare sector's role here should be, or really what high quality social care should look like? And it turns out that I think everybody who's involved in that policymaking was actually struggling with those same questions. Because I think that's the confusion that explains why the different policies that emerged in this space actually differed quite a bit from one another. So they differed on things like what domains they included, what instruments they recommended, how frequently screening should be done, who the target population should be, whether the standard should include screening or screening and an intervention of some kind, and then what kind of intervention, and then how the information would be reported. I just want to highlight those differences so that you can see concretely how that played out. So again, in 2023 and into 2024, the NCQA, National Committee on Quality Assurance, the Joint Commission, CMS, all introduced measures intended to incentivize social risk screening, and in some cases, interventions. Now, in 2025, admittedly, CMS actually rolled their measures back in the programs where they had been adopted, but NCQA and the Joint Commission haven't changed either their HEDIS or their hospital accreditation guidelines as of yet. And despite the CMS changes in 2025, it may well be that CMS is not entirely out of the game. In fact, just last week, the Medicaid and CHIP core set working group just recommended that social needs screening and referral quality measures be included to evaluate Medicare and Medicaid services for children and adults nationally. So we'll see if CMS actually adopts those recommendations or not. But I don't think CMS is out of the game. What you'll see here is that all of the measures differ a little bit on all those characteristics that I mentioned just a minute ago on the last slide. But one of the most fascinating things about all of these measures is that they encourage healthcare organizations, whatever the level of healthcare organization, to increase screening without any accountability for the quality of the screening or subsequent interventions that are being done. Again, this is just showing that CMS actually moved away from that measure, but it's still out there in some form. So setting aside all the arguments for and against social risk screening generally, which actually has been the focus of some of our other webinars and papers and some of the other conversations that we've hosted. And you can go and find those on the website if you're interested in the SIREN website if you're interested. One of our big concerns is that increasing quantity of social care in the healthcare system can sometimes mean decreasing the quality of social care in the healthcare system. So against that policy backdrop, at SIREN, we partnered with Kaiser Permanente to explore the development of a patient experience of social care measure that could serve as a counterbalance to the more quantity-focused measures. And from there, Andy and Danielle are going to share the details about our journey. So Danielle, I am going to turn it over to, no, Andy, I am going to turn it over to you.
Great. Let me just share my screen real quick here. Looks okay. You guys can see it. Great. Thanks for having me, you guys. So just like Laura was saying, there's been this question around quality, quantity, but then there's this bigger question of, okay, what does quality in social care look like? And what I'm going to talk about today is what our understanding has been of what quality in social care looks like from the patient perspective and the patient experience perspective. And one of the things I want to highlight is that in our journey to understanding this, we really started with patients themselves, with patient advisory groups that had folks with lived experience, and obviously relevant literature to inform our project. So I'm going to spend a little bit of time here talking through our journey about understanding what drives patient experience of social care, what drives positive experiences with social care in healthcare settings, and what this project has looked like in terms of capturing those drivers of patient experience, and really creating a measure to measure that and to capture that. And I know most of you are probably here to, what is this measure? What is this patient experience of social care measure? Show me the questions so we can use it, so we can take it back. And I'm just going to take a step back, and I really want to do a quick deep dive into the qualitative work that really served as the foundation for how we developed this metric. And briefly, what we did was really captured like the language, the drivers of what patients told us contributed to positive and negative experience of care, and developed survey items to capture those components, refine the items, and then validated and tested them. So with that, I'm just going to do a quick dive on the qualitative phases of the project. So we conducted two qualitative studies, with one analysis really identifying the key drivers of patients' experiences of social care, and the second one exploring the role that racism and race and ethnicity may play in patients' social care experience. We interviewed 30 patients. They were all Spanish or English speaking adults in the US and had experienced healthcare-based social care in any healthcare setting. And we conducted thematic analysis, and we really sort of pulled from patients' own words and experiences about what drove their experience. And these were our participant demographics. Again, 30 patients who had experienced social care in healthcare settings over the last 12 months. And these are the race and ethnicity demographics, with most Latina patients being Spanish preferring. And most of our participants had experienced healthcare-based social care in adult primary care. And really, it was mostly in urban healthcare settings. So what did we find? What really drove patients' experiences, positive and negative? And what we found is that these were sort of split into two broad domains, or components: the functional components of social care, what we usually think of as like the more operational, like, did you get screened? Was it a paper screening? Was it a computer? Who screened you? Where was it? Was there follow-up? Did you receive a referral or a resource? And then there were the more relational components of social care, which was really like, how was the social care provided? What was that social care encounter like? And what was really interesting is that the how of social care was delivered was as important, and in many cases, even more important than what social care was delivered. One example is that there were several participants in our studies that would say, like, yeah, I got a resource voucher, I got food resources, and yet they recounted their social care experience as negative because of their social care encounter with a provider. They felt judged, or they felt like they were misunderstood, or they were scared to engage in social care. And so essentially what we found is it's not just what we provide in social care, but how we do it. That's really, really, really important to patient experience and their perception of the quality of the care that they receive. We also found that these functional components, like the operational components and the relational components, were actually related and sort of fed into one another. And the clearest example of this is actually follow-up. When participants were asked about, okay, like, did you receive follow-up? How did that feel? What do you think about that? Was it valuable? Follow-up for after being screened and after being given resources was really important for patients. And what they described was actually it just, it didn't really matter. It did matter if they received the resources, but really what really brought value was feeling like their provider cared about them, like their healthcare clinic really cared whether or not they had their social needs met. And conversely, we also saw how relational components influence the more functional components. So we had many participants where, like, yeah, there weren't enough resources or the referrals didn't lead to anything, but the emotional support that they received from their provider throughout their social care, whether it was the primary care provider, the community health worker, made them feel supported, even if there were no resources available for them. Um, and and this was a recurring theme when we asked patients, what they valued the most, and the emotional support and the support with distressing needs was hugely valuable to patients. Um, and this is an example, a patient quote that really exemplifies how this, like the importance of this relational component and how patients are actually attuned to the intentions behind social care screening and resource delivery, and whether clinics or providers actually care about them or they're just checking a box. So this participant says, I just think it feels like they're just data collecting. They're not trying to help, which I wish they did because I feel like it would benefit those who actually suffer deeply. Um, and again, we asked participants what they valued the most out of the social care experience that they'd had. And some of them said, it was the resources, it was the help with housing, it was what I received. And some people were like, it was the emotional support. It was the feeling like my provider actually cared about me. And at the same time, we also got a little bit of pushback from our participants because, like a good researcher, we were good researchers. We were trying to figure out, like, what is the most valuable thing to people, right? And this second participant here, when I asked her, like, okay, so what was more important, food stamps or the emotional support you got? She said, that's a paradoxical question. Answering one way makes one seem less important, but they're both important. Um, we also, like I had mentioned before, we also did a deep dive and a second analysis on the experience of Black and Latina patients of social care and the impact that racism may have on their social care experience. And what we found was that racism in all its layers was hugely impactful, hugely influential in our participants' experiences of social care. Um, when we asked participants if they felt like their race or gender influenced their care, folks really brought up stigmatizing narratives around race, poverty, welfare, and government services. And we found that these things, like these narratives, were really front of mind for patients, for our Black and Latina patients, when they engaged in social care. And we also found that experiences of racism in medical care fueled participants' distrust in healthcare-based social care. And that really influenced how they engage, how they felt, and the hesitation and distrust that a lot of our participants felt in engaging with healthcare-based social care. And these are two quotes that really exemplify this. The first one is worried, I'm a new patient. I've never met this person. I'm filling out all this information. Am I going to be judged by this? And this second participant says, I didn't want to be a stereotype. I was hesitant to really answer truthfully the social screening questions because I was worried about being a stereotype. And we also found that this distrust really fueled disengagement in social care, and participants would withhold actual social needs on screening, and they would decline services that were offered. Um, and I think this really underscores the importance, and just bringing it back a little bit to why we're doing a deep dive on this, it really underscores the importance of having a patient experience measure and really taking it seriously as a part of how we assess the quality of social care and really understand what's actually happening when people screen negative for social needs, or what's actually happening when they are not linked up to social care. Um, this is a couple of examples here about this disengagement. This participant says, the question with this initial social worker, they were very biased. I don't think I want to answer any more questions. She just wasn't sensitive. And these are all quotes from our Black and Latinx participants. And then this participant said, well, they called in the social worker, and the first thing I felt was fear. I was thinking they'll take my children away from me. And I was so afraid that I took the pain medication they gave me. I went home and I never went back. And before I end, I also just want to highlight that we interviewed participants that also had really positive experiences of social care, um, and things like cultural humility, um, racial and ethnic and cultural concordance, language, compassionate interactions. These were all things that really made for positive experiences of social care and engagement in social care. Um, and again, just to go back to sort of like the initial project here, what we tried to do is really like identify these key drivers, these key things that really made for quality social care experiences for patients, and came up with about 30 questions, 30 survey items to try to capture these elements that were so important to patients. And we refined them. We did many cognitive interviews with patients, trying to get the wording right, making sure that what we thought we were asking was actually what was understood by the participants. And then the survey was validated and tested. And with that, I'll hand it over to Danielle to talk a little bit more about the actual measure itself.
Thank you so much, Andy. That was fantastic. And thank you all for joining us here today. All right. Is everyone seeing my screen okay?
Yes, perfect.
Fantastic, fantastic. So as Andy was so eloquently sharing, this was a multi-phase endeavor. So this was definitely a journey we've been on over the last 2, 3 years. Who's counting? What is time? But after, as Andy was sharing, after that qualitative work, we really that wasn't the end, right? That was a new beginning to have to as much as we could, we were using the wording that individuals who had experienced social care to form those items and then go through this process, as Andy was saying, with cognitive interviews, where we kept refining that language and refining the wording that individuals would see on a piece of paper of a measure to see, was it clear? Were there different ways of interpreting the question? What did it feel spot on? Did it feel like something they would want to answer and feel confident answering? And so all of that led up to the words that ended up on the page for a set of survey items for this measure. And so where I'm going to jump in here is telling you the next chapter in this tale around the validation of the measure and where we ended up. What are these questions, right? So what we were seeking to do at this phase was to answer the question, is this measure statistically reliable and valid? Is this something that we could put forth here and share with the world? And the way that we went about this was that we took these items And we partnered with Frisia to distribute a national survey to patients and caregivers who had engaged in social care, who had been asked questions around their social and financial challenges. We then took those survey results, and what I'm going to share with you today is we did what's called psychometric analysis. We examined the reliability, the validity to see how did these items stand up. And at the heart of this, our goal was to select a parsimonious set of items that were reliable, valid, and meaningful to our partners. And partner at the heart of our partners are those who are experiencing social care, those with the lived experience as patients and caregivers. So diving right in, we through this partnership with Frisia, surveys were collected from 644 patients who had experienced social risk screening in a healthcare setting in the last year. So they had access to data across 31 states of patients or caregivers who had been asked screening questions in a routine healthcare setting. Um, you can see the patient demographics here in terms of who responded. So we did have about almost a third of the sample that was a pediatric sample. That means that their adult caregiver was asked the social risk reading questions and about this quality of their experience. And then almost half the sample between 18 and 64, 22% over 65. We had a split on gender identity, and then you can see that a little over a quarter of the sample identified as African American or Black, 16% Hispanic or Latinx, and 46% white. Really a mixture in terms of insurance, and again, representation over 31 states. So, a little bit more about the folks who participated in answering these questions. When they were asked the social risk screening, they were all screened for food, housing, and transportation challenges. And almost half of them were screened very recently. So they were reporting on their experience of when they were asked these questions. So 45% of them, they were asked under 3 months ago from the time when we asked them about their experience. All of them were asked within the last year. Around half were in a primary care setting, the others in another healthcare setting, and they were really spread in terms of whether or not they identified social risks. So 30% when they were screened reported no social risks, 50% one, and then we see less for two or three out of the three core areas we were looking at. Interestingly, only 200 reported receiving assistance. Assistance meaning some form of assistance provided, whether or not those are resources, referrals, etc. And you see the breakdown here below of we had about a quarter of those who completed our patient experience measure desired assistance, and they received that assistance. However, 26% desired assistance and reported that they didn't receive assistance. And then we see most of the remainder did not desire assistance and did not receive it, and a small amount did not desire it, but they did receive it nonetheless. So at this point of measure validation, when these items had gone through that process that Andy and I both described, we had 13 items that we evaluated that these over 600 people responded to about their experience of social care. We then went through and did some statistical steps to evaluate these items. So we first did some descriptive statistics. We looked at the range, we looked at the distribution, we looked at the intercorrelations, and right away we saw that there were some items that even though it had gone through all this testing, that were having poor item distribution, meaning two of the items were removed because they were very, very skewed. Very, very few people endorsed anything other than the far end of the scale of it, essentially it not coming up for them. We also had 4 items that we removed due to very high conceptual overlap and correlations with the other items. So in measure development, there's always a tension, a tug of war about wanting to ask everything because it's all important, it's all near and dear to our hearts, and it's hard to cut things. And at the same time, remember that word parsimonious that I threw out a couple times. There's incredible pressures, we know, whether you're a researcher, whether you're on the front lines of healthcare, whether you're a policymaker, of making things short, making sure every item counts, that every item is really telling us something, something unique, something, and preferably something we can really take action on. So we did remove 4 items that really seemed like they were overlapping with those other items conceptually. We then put these remaining items into what's called an exploratory factor analysis. And those were 2 exploratory factor analysis. One set of items was around individuals' experience of sharing their social or financial situation, and the other was around their experience of assistance. And what we're looking for in exploratory factor analysis is essentially, are these items hanging together? Are they part of the same concept? And how much are they contributing statistically? And for those of you who like to follow the math, we had eigenvalues above 1. They yielded a single factor each. All the loadings for the individual items were above 0.80. And for those of you who don't follow along with factor analysis numbers, this meant it really hung together. These were really solid numbers. We then took those same items and those two same factors, the experience of sharing the social or financial situation, and then the second one is the experience of assistance. And we looked at what's called Cronbach's alpha. This is a measure of internal consistency. And again, for those who are interested in the numbers, we had numbers in the mid to high eights, as you'll see here, 8.89 and 0.86. These are strong internal consistency. So again, this is signaling to us statistically that these items are working together conceptually, that conceptually they're part of these umbrellas that they're under of the quality of social care. And so a lot of you are probably wondering, okay, we're 35 minutes into this webinar. What are these items? Well, here they are. Here are the items. So these were the 7 items that made it through this rigorous path. And for each of them, we asked individuals to think about the last time that they were asked about their financial or social situation, such as housing, food, job, transportation, utilities, affordability, in a healthcare interaction. So again, thinking specifically about a healthcare interaction. And you'll see the wording of the 4 items that were about being asked, their social financial situation here at the top. I understood why I was being asked questions about my social or financial situation. My care team talked to me about my social or financial situation clearly and in my preferred language. I felt like I could trust my care team with information about my social or financial information. And my care team asked me about my social financial situation in a way that was respectful towards me and my culture. And if you'll remember back to what Andy shared about a lot of what we were finding in the qualitative work, the importance of trust, language concordance, language in general, respect, cultural understanding, a lot of that was really influential into this set of questions here. And then the second set of questions ask about the experience of assistance if it was provided. So there, the 2 items are the resources, information, or referrals I received were up to date and relevant to my situation. And the resources, information, or referrals I received helped me with my social and/or financial situation. We also last had a single overarching item that if you have experience with CAPS measures or other patient experience measures, you may recognize this structure. A single overarching item to understand overall experience of social care. How would you rate the overall experience of sharing your social or financial situation in that healthcare interaction? And in terms of, what do these scale scores look like? Well, here what we see are the means, medians, and ranges of those three measures. So first, on the experience of being asked, a social financial situation, we see the full range of scores. So these were asked on a 1 to 4 scale, 1 being a low rating, a poor rating of that social care experience, 4 being an excellent experience. We see the mean hover a little bit less than 3, but the full range being used. So there are people saying the lowest score on each one of those items, as well as people saying the highest. Similarly, on the experience of assistance, of receiving those resources, referrals, and information, we see that mean a little bit higher, a little bit above 3, but that full range of scores being used. And last, on the overall experience of social care, this was rated on a 0 to 10 scale, 0 being the worst possible interaction and 10 being the best. And here we see a mean around 7 with a median of 8. However, that full range again being used. So individuals are really varying in their experience. This final set of 7 items can be used together or separately. So one of our goals here was to create a parsimonious short measure that could be impactful, that could be action-oriented, but that also could be flexible. So for instance, some individuals may really be wanting to focus on everything. We love that. We welcome it. Others may be wanting to really focus on assessing that experience of assistance. And so these can be used in combination or individually. I can tell you that statistically, the 3 scales are correlated with one another. Pearson correlations in the zero point 0.5 to zero point 0.6 range. What this suggests, at least to us, is that there's, again, conceptual coherence. These are very much intertwined measures. However, they are not overlapping. So just because we know your score on what you thought about your experience of being asked doesn't necessarily, it correlates, but only 0.5, zero point 0.6. It still, has some independence from your experience of the resources and referrals. So we think each one of these components is really important to assess and pay attention to. And then in terms of the external validity, we also looked at, well, what are these measures related to? Are they related to the things we think that they should be related to if we're measuring what we think we're measuring? And the TLDR is yes, we found strong validity, but the details here are on the slide. And so once again, on the left, we have our 3 measures: the experience of being asked, the experience of that assistance, and the overall experience of social care. And what you're seeing here are the Pearson correlations. We were relating it to things on starting at the left that we thought it would be most strongly related to. So ratings of that healthcare visit overall when they were asked about their social situation, whether or not they felt respected at that healthcare visit. And then if you follow your line going a little bit more here to the right, ratings of their healthcare in that same setting over the last year, feelings of respect in that healthcare setting in the same year. So we're seeing moderate to high correlations, strong, certainly very significant correlations. We also saw a relationship with whether or not they recommended the healthcare setting to another. So in each of these cases, these are positive correlations, meaning the more positive their experience of social care, the more positive their ratings of the healthcare visit, their healthcare setting, and their likelihood to recommend that healthcare setting to another. Now, interestingly, as we move even further right on this table to general health and mental health, these are items from the promise measure. So this is their self-reported general health and mental health. And we were seeing, although not as strong, and we wouldn't expect as strong as correlations, we were seeing that more positive experiences of social care on this new measure were related to better ratings of general health and mental health. And then at the far right, we did have one measure of what we call discriminant validity. This is a measure we thought our measures shouldn't really be strongly related to. And so for that, we asked individuals whether or not they had received their flu shot. And as you can see, those correlations were quite a bit lower, showing that overall our measure was related to the things we thought it should be related to and was not related to the thing we didn't think it would be strongly related to. And then just to wrap up here with a couple last slides, we also looked at what are these scores related to? What are some other correlates? And so one of the first things we looked at is whether or not the patient experience of social care scores, these ratings, were linked to demographic factors such as gender identity, race, ethnicity, language. And what we saw was that it was not. There was no consistent linkage there. So it wasn't that individuals of a certain age or gender or racial identity were systematically having higher versus lower experience scores. We did, however, see that higher or more positive experiences of social care were linked to a few things in our data, and those are listed here. When the social care occurred in a primary care setting, we saw overall higher ratings on average. When someone endorsed more social needs, they had a higher rating. When there was a shorter duration since the social care. So if we asked this experience, this experience measure closer in time, then there was a more positive rating. And then these last two on the right, I want to emphasize receiving assistance and receiving follow-up, meaning after that first point of assistance, if there was some sort of check-in around a social financial situation, both of these were strong drivers of seeing higher experience scores. So in summary, the patient experience of social care measure that we have developed is the first measure. It's not the first measure ever out there to try to pick up on some of these things, but we do believe that it's the first measure that we're aware of with items that were developed from patients with the lived experience of social care in healthcare settings. So this was really driven by what patients were telling us as the through line all the way along. And the three scales that can be used separately or in combination, 7 items in total, we believe can assess social care overall experience as well as these at an item level, these distinct actionable elements of social care, meaning that it's our great hope that from a QI lens, these individual items can be looked at of where improvements can be made. The measure has strong internal reliability, consistent validity. And this average rating that we saw, at least in our sample nationally, suggests that many people have not had positive experiences with social care. It also suggests specific areas for improvement. And this is at the heart of why we set out here. We set out to make a measure so that we can know how are things going and how can we make them better. So in conclusion, the quality and quantity of social care we see as different concepts. This measure, we believe, can serve as a useful counterbalance to the existing quantity-focused measures. So as we're out there and we're seeing measures stress the quantity, the number of people screened, the number of people who received a resource, we don't want folks to lose sight of the importance of quality. So we can think of this as two scales. We can be increasing quantity while also be increasing quality. And we think that this measure can help us get a handle on that quality and where to make improvements. Individual health systems can use the measure to improve the quality of their social care practice. And in parallel, we hope that state and federal policy can incorporate this or other patient experience measures into their quality measurement strategies. And with that, I want to turn it back over to the group to get into questions.
Thank you so much, Danielle and Andy, for those great presentations, and to the audience for all the kudos that they're handing out here. Thanks, everybody. We have so many questions in the chat. We probably won't be able to get to all of them. I'm going to try and pick up on the ones that I think are probably most interesting for group conversation. And actually, Andy, I'm going to start with one for you from our beloved Lowell Solomon, who points out that it's such an important finding about prior experience of racism influencing expectations and current experience of social care. So his provocative question is, what does that mean for social care? What do we do with that? And I feel like you've thought a lot about this and taught me a lot about this, so I would love to hear what your thoughts are.
Sure. Thanks, Wolf, for that question. Um, I would say if we take a step back and we think about the drivers, right, sort of the relational and the functional or operational drivers of social care, I think in terms of like actionable things is how do we operationalize those trust promoting factors, right? So, who are you hiring and who are you training to do social care? Are they folks that are culturally concordant with your patient population? Are they folks that speak the language of your patient population? Do you have interpreter services available? How are you thinking about the quality of social care delivered? Are you thinking about it as just checking a box and trying to get through as many patients as possible? That's probably not going to engender trust in communities that have great reason for distrust in social care. And then it's also sort of like this relational component, right? We have to enter social care with the humility of understanding that there's a broader social ecologic context to social care for our patients that maybe medicine hasn't been attuned to because we've been in medicine land. And so I think it's sort of like our providers need to know that this is part of what patients bring into social care encounters, and we have to be humble to that. And just as seriously, operationalize the things we know that engender trust in social care for communities of color. I have more to say, but start there.
You know where to find Lowell. Those are great. There actually are some other interesting questions that are coming up in the chat, and I'm going to group them a little bit to try and get to more of them. But in part related to this question that you've been answering, Andy, and then I'm going to draw Danielle in too. Both Ron and Caroline pointed out that there are some things there were some variables that were associated with differences in scoring on the social care measure, and there were some things that were not. So like, given what Andy has been talking about and all of the qualitative work that they did, were we surprised that race and ethnicity weren't linked to the responses to the measures? And then similarly, there were some things that were associated and some things that were not that were surprising, also related to age and education. And Ron actually asked a specific question about education. So Andy, let's start with you, and then Danielle, maybe you can go a little bit more into the associations we found.
Yeah, I mean, I think I was surprised. And I also think Danielle would have a better grasp on the demographics of the patients surveyed for validation and testing to have a better answer to that question. But Ron's points are well taken. Yeah.
Yeah, I mean, absolutely. I was absolutely surprised. I think I think that we did expect to see some associations there.
Mhm.
And at the same time, I think that we were seeing that many individuals of many identities were experiencing lower ratings of social care. So it's not that, everybody was saying it was great. I do think that we were limited by our sample, and this touches on a couple of the really keen observations in the Q&A of that, a validation is one validation is only one validation, one group. While we strive to make it not limited to one healthcare system or one geographic area, it's not, it's not like this is where the story ends for validation. So there are many voices still at the table who weren't here in this validation sample. And so I think that we have to also take into account we only had a few demographics to look at. So education level was not one of them. And so there's a lot of other considerations here for more validation work in additional samples.
Love it. So there are a number of questions in the chat about, well, how do you scale and implement? Like, is the vision that this is going to be part of everybody's social care practice? How would you implement it in a non-research setting? What does the vision look like? Do you guys want to jump in on that? And I'm happy to add thoughts after. Andy, are you going to
Yeah.
implement this at Alameda Health System as an example where you have all sorts of influence now?
Well, you know, I think different systems are going to play with this differently. And throughout this process, the part of this process has also involved a lot of input and feedback from people in different healthcare systems, different researchers who are like really eager to play with this. And I think we're going to learn a lot from their experience. I also think we're at a time in which resources in healthcare are being cut. And um, social care programs and social care programming is really looking to really display and really highlight the value that they bring. And you know, I think the fact that this is a good measure that it sort of tracks together and individual questions can be used also means that people are going to be able to use it confidently in a flexible way. Um, and if we think about safety net systems as being the places where the highest volumes of folks with the highest levels of social need are, I think that's where we're going to see this implemented a lot. And I think we're going to learn a lot from it. I don't have a lot of answers, but I'm excited to, you know, get people's experiences and implement it as well.
Danielle, any additional comments on that one?
Well, it's music to our ears of anyone out there looking to implement. This is one of those measures where when we've been talking about it, it has been wonderful to hear from folks across the country reaching out to us during this development process of when can I use it? So I do think that it's always tough to introduce a person-reported measure. That's always going to take work in a workflow. At the same time, I think that there's a lot of people out there who are feeling right now, I don't want this to be a checkbox of providing social care. I'm very worried about what's going on and what I can do to ensure the quality. So we have heard from multiple folks in health systems an interest of really putting this to work and trying it out. And that's what this measure needs. We need to try it out and improve it all together.
Right. And I will just add one more kudo here to KP, actually. So Kaiser Permanente, the reason that they wanted to support the work around developing a measure is because they're um, so committed to making sure that the work that they're doing in their own system around social care is of high quality. And so I think it's a great example of how, yes, I do think that the future is that that institutions that are committing to social care may also be committing to high quality social care. That's not universally true, but I think that is true in some places. And so that gets to this other question that came up in the chat about like, well, how do we increase the political will? That part is I don't know that we figured it out, but I know that there are some institutions that have at least the internal will, the organizational will to improve the quality of the work that they're doing. There were a couple of questions that we just have a couple more minutes, but there were a couple of questions that were related to um, maybe like future studies and kind of maybe past tense and future or past study and future study. So Lowell asked, like, what is I'm trying to find the actual question. Uh, I lost it. You asked a question about like what is the uh, uh, Does patient experience of social care influence the willingness to accept social care from a healthcare provider, not a party? Are you planning something like that as a follow-up study? And then similarly, Arwen was asking, do we know about, like, is this related to who delivered it? Was it on paper? Was it in the clinic? Was it by a social worker? And then somebody else asked, like, could you use it in a community setting versus only in a healthcare setting or whatever? So, Danielle, maybe you could take a second and just talk about, like, we didn't do any of that, but what would be your dream next study beside just validating it in different communities? Like, what would be your dream next study?
Yeah. Oh my gosh. You know, I love dreaming about next studies. So yes. So a lot of things, such good ideas, things that we weren't able to do here that we want to do. Please, everyone, go forth and do it. If I had to narrow it down to one dream next study, it would be working with a set of organizations that were committed to improving the quality of their social care, where they could put forth and use the measure, and then we could work as a learning collaborative together to drill in and think about where improvements can be made and take those actions.
I love it. Andy, what about you? Do you have a dream next study before we close?
Yes, and I think in addition to what Danielle said, I think there's been some chatter about this in the chat about what the influence of quality social care is on the quality of healthcare delivery and healthcare experience. And I think it would be really interesting to explore once you increase the quality of social care delivery, what impact that has on patients' engagement with healthcare in general.
I love it. There are, as always, more questions than we can answer during the webinar. We encourage you to reach out to us directly. You can write to SIREN at ucsf.edu and throw more questions in there. We will make the recording of the webinar available to everybody who registered for the event, and we'll link some resources to that. Please do check out the landing page that we provided in the chat, and we'll include it also in the follow-up so that you have access to the resource and then the related publications about the actual measure set. Thank everybody for participating today. Many thanks to our panelists, and we look forward to hearing from you. Happy Thursday.